Now I will like to invite Dr. SAURABH LUTHRA for his presentation on basic imaging in uveitis, fundus fluorescein angiography, ICG and autofluorescence, sorry.
Good afternoon. I thank Professor Biswas and AIOC for this opportunity. So Dr. Risha has nicely set it up, and actually it's multimodal imaging which we normally use these days, and all the modalities you'll see can be combined very nicely to achieve a diagnosis. Thank you to the panelists as well. So I'll be just showing a few cases, and these are my acknowledgements. And we all know that FFA and ICG has certain differences. That fluorescein is mostly protein bound, 80%, and 20% is free, whereas ICG is about 98% protein bound, only 2% free. That's why in the fluorescein it escapes the choriocapillaries and causes a lot of leakage, hiding the underlying details, whereas ICG does not escape, and that is why it is better for choroidal pathologies. And this flowchart is very nice. It's from a paper by Dr. Carl Herbert way back in 2009, and it kind of nicely summarizes how fluorescein and ICG can be used for diagnosis. So I'll just show a few quick cases. This is a case of peripheral retinal vasculitis in a 59-year-old male with floaters for the past 4 months in the left eye. Disc was within normal limits. There was a fine ERM with multiple peripheral NVEs with few perivascular CRA patches, and left eye also had an old vitreous hemorrhage. So this is how the the FFA picture looked, and you can see the changes in the peripheral retina, the staining of the vessels and CNP areas. HRCT thorax, there was no active lung lesion, pleural thickening and calcification was present. The MANTU was 25 millimeters. ACE was normal, VDRL was non-reactive. Both eyes underwent PRP laser and under oral and topical steroids and ATT cover. So this is how it looked like at presentation. This is another case of peripheral retinal vasculitis, again presenting with floaters for the past 1 week. Vision was 6.6 OU, and there was NVD in the right eye with vitreous hemorrhage, and both eyes had NVEs, RPR. So this is what the picture of the FFA looked like. You can see gross capillary non-perfusion in the periphery here, almost wiped out, capillary bed in the periphery. There is some perivascular staining, and this in the right eye is block fluorescence due to vitreous hemorrhage. The serum RPR was non-reactive, ACE was 15, CBC was within normal limit, X-ray chest was normal. Patient underwent again PRP laser to avascular retina under topical and oral steroid cover. In this case, we didn't give ATT because there was nothing to kind of point towards that. So again, this is the picture of the other eye of the angiogram, which showing extensive capillary non-perfusion areas. We can have syphilitic multifocal choroiditis. This is a young male, VDRL, TPHA positive, and a tongue chancre history he gave. And vision was 6.18 in the right eye, left 6.9, improving to 6.6, and there were vitreous cells in both eyes, and this is what we saw on the fundus photograph, where you can see light chorioretinitis patches and with some hemorrhages, and there's a disc edema in the right eye. VDRL was reactive, TPHA was positive, ACE was normal, chest X-ray was normal, MANTU was negative, ANA was positive, and HIV was negative. And this is the OCT, and OCT has nicely been covered by Dr. Risha, and you can see the hyperautofluorescent areas more in the right eye showing active choroiditis, and this is what the FFA ICG looks like, and you can see hypo with hyperfluorescence and lot of hypocyanescence also in both eyes corresponding to the areas of activity. There was no neurological sign symptoms, and treated with oral and topical steroids and 3 doses of intramuscular benzathine penicillin for 3 weeks. Post-treatment, this is what the fundus picture looked like. BKH has already been shown on the OCT. Basically, patient has a lot of inflammation, and there are multiple choroidal granulomas with disc hyperemia, and there is early pinpoint hyperfluorescence, as you shall see soon. In the OCT, you can have these folds or undulations at the level of the choroid and retina with subretinal fluid. And obviously there is disc edema as well, which is again a hallmark of VKH, acute VKH. And you can have early pinpoint hyperfluorescence and late pooling of the dye here, you can see on the angiogram. Again, you can see early pinpoint hyperfluorescence and late pooling of the dye in the late phases. So in this case, there was bilateral pleural thickening, and CBC ESR was normal, ACE was normal, VDRL was non-reactive, and patient was given oral and topical steroid and then put on immunosuppressants in the form of azathioprine, which the patient took for the next 6 to 8 months, and patient continued to be fine. Azure is another condition in 30-year-old males presenting with scotoma in the right eye for 1 week, left eye 2 months, best corrected vision was 6.6. Diagnosed elsewhere as glaucoma or query CSR, and white dot syndrome also was made, this diagnosis. And you can see here on a cursory examination, on a fundus examination, you can easily miss this condition. The fundus is fairly normal looking, but on autofluorescence, it's quite remarkable. You can see these hypo-autofluorescent background and these hyper-autofluorescent speckled patches, especially in the juxtapapillary area and also nasal to it. In the left eye, it is a kind of established azure, whereas in the right eye, it's acute. That is why you can see that the right eye vision is, the scotoma is more dense in the right eye. And this is what you see on FFA ICG. You can see actually a tri-zone. Three zones are there in which there is a hypo and a hyper and then again a hypo. In the juxtapapillary area and also nasal to the disc, and on the ICG you get a very clear-cut area of hypocynescence, which is quite remarkable. And that a similar picture in the left, but it was more chronic, so in the right eye it is more an acute presentation. And this is 3 months post-treatment, vision OU became 6.6. And so this is how you picked it up on the fields. You can see in the top left that there was a dense scotoma involving the fixation and the blind spot, more so in the right eye. Left eye is a healing or a resolving azure, so you can see scotomas are not that dense, but with follow-up, these scotomas, they resolved. Choroidal granuloma has already been shown on the OCT. This is a 43-year-old woman, right eye black spot, and history of 1 month being treated with oral corticosteroids and first line 4-drug ADT, 6.6 OU. And fundus showed a choroidal granuloma in the right eye. Mantle was 30 by 30. Positive IGRA and HRCT chest was normal. And PET CT showed some lymph nodes. And this is a very old patient actually, so I'm sorry for the poor quality of the angiogram, but you can see here that this is actually a very important telltale sign on fundus photography, which Professor Amod Gupta has taught us, that there is a chorioretinal anastomosis and you can have a hemorrhage overlying this granuloma. So this is a telltale sign that this is a TB granuloma. And you can see initial speckled hyperfluorescence and later on lot of intense hyperfluorescence in the area of the granuloma. Mantle was 30 by 30, HRCT